Welcome to the Hospital Medicine Unplugged podcast.
Today, we're embarking on a deep dive into non-alcoholic fatty liver disease, or NAFLD. And for the hospitalist, this isn't just some abstract outpatient diagnosis anymore, is it?
No, not at all. It's something we're seeing constantly. It's a rapidly escalating issue that really forces us into complex risk stratification, and it dictates long-term discharge planning for a huge number of our patients.
Yeah, absolutely.
That's really the core of our mission today, I think.
Yeah.
We want to move beyond just recognizing NAFLD. We need to distill the current evidence-based guidelines for, rigorous risk stratification and management. We need actionable steps, things we can actually do on the wards.
Focusing specifically on maximizing prognostic accuracy, right? And efficiently guiding who actually needs that hepatology referral.
Exactly, because the clinical urgency is, frankly, immense.
It really is. This is a global epidemic. We're talking roughly 25% of the adult population worldwide affected. So when you see a patient maybe with elevated LFTs, or even just, incidentally detected fatty liver on a CT scan.
Which happens all the time.
All the time. You have to immediately appreciate the potential long-term spectrum of this disease.
And that spectrum,
Yes.
that's where the stakes get really high. It starts simply enough, right?
Right.
Non-alcoholic fatty liver, NAFL, essentially just simple steatosis.
Just fat in the liver.
But for some of those patients, it progresses. It moves to non-alcoholic steatohepatitis, NACA, and that's where you get inflammation. And crucially, fibrosis starting to build up.
And from NACUJ, the path leads towards cirrhosis and ultimately potentially hepatocellular carcinoma, HCC. It's a serious cascade.
It is, and the pathobiology seems inseparable from the metabolic syndrome cluster.
Oh, completely. We're talking obesity, type 2 diabetes, dyslipidemia, hypertension. When you see this cluster in a patient, you know their risk is heightened. But here's a critical distinction, something we really need to internalize as hospitalists. Okay.
While the liver damage itself drives significant morbidity, we have to remember that cardiovascular disease is actually the leading cause of mortality in the NAFLD population.
That's a huge point. It's often missed when we're just chasing liver enzymes, isn't it?
It really is.
However, when we drill down into predicting the liver-related outcomes, who decompensates, who might need a transplant down the line, it all comes back to fibrosis.
Exactly. The degree of liver fibrosis is the single strongest predictor of both hepatic and overall prognosis.
So while we absolutely have to manage that cardiovascular risk aggressively,
Which we do.
our primary screening imperative, especially concerning the liver itself, has got to be staging the fibrosis, staging the actual liver damage.
Precisely. If we accept that fibrosis stage is the most important prognostic marker, then our clinical thinking, right when that patient hits the door, has to shift. We need to immediately focus on identifying who is at highest risk for already having advanced fibrosis, or perhaps who is on track to progress rapidly toward it. Okay, so let's start there. Let's talk about those risk factors, particularly the metabolic drivers. These are often, glaringly obvious in our inpatient population.
They really are. The primary metabolic issue stems from insulin resistance that drives central adiposity, that visceral fat deposition.
Right.
And that visceral fat creates this increased flux of free fatty acids straight to the liver. That leads to leukotoxicity, inflammation. And that's the switch. That's the transition from simple fatty liver, NAFL, to the inflammatory state, NASH.
So practically, on admission, we're looking aggressively for things like uncontrolled type 2 diabetes mellitus.
Definitely. Significant insulin resistance markers, if available, and that specific pattern of dyslipidemia, the low HDL cholesterol coupled with high triglycerides.
Got it. Low HDL, high triglycerides.
And hypertension, of course. And increasingly, we're recognizing obstructive sleep apnea as a strong risk accelerator, too. It's often overlooked, but important.
It really sounds like NAFLD is less a primary liver disease and maybe more of a systemic metabolic disease that just happens to manifest quite severely in the liver.
That's a great way to put it. It's a hepatic manifestation of a systemic problem.
Okay, beyond the metabolic factors, what about the non-modifiable things or demographic factors that should raise our suspicion?
Yeah, there are definite patterns. We see higher prevalence and often more severe disease in certain groups. Older age is a factor, male sex. And notably, Hispanic ethnicity is consistently associated with higher rates and severity.
And this isn't just environment or diet, right? There's a significant genetic component here, too.
Oh, absolutely. And this is critical when we're taking a history, especially a family history.
Could you elaborate maybe on the key genetic variants, the ones we should perhaps be aware of?
Sure. The most well-studied, the one people might have heard of, is the PNPLA3 I148M variant. It's strongly associated with increased susceptibility to NAFLD, NASH, and even HCC. And importantly, often independent of those classic metabolic risk factors we just discussed.
So someone might not fit the typical metabolic picture, but still be high risk due to genetics.
Exactly. And there are others, less common perhaps, but still important, like variants in the TM6SF2 and MBOAT7 genes. So if you have a patient admitted, maybe with a relatively low BMI, but they mention a very strong family history, say, a parent or sibling with cirrhosis of unknown etiology.
You need to think genetics.
You absolutely must consider this genetic predisposition and probably accelerate your screening pathway for them.
Okay. And once that inflammatory component of NASH really kicks in, the speed of damage, the fibrosis progression, it accelerates dramatically. Can you detail that difference?
Yes, and the data here really makes the case for early identification and intervention crystal clear. So a patient with just simple NAFLD, just the steatosis, typically progresses maybe only about one fibrosis stage per decade. It's relatively slow.
Yeah.
However, once that patient has biopsy-proven a NASH inflammatory disease, the progression velocity more than doubles. They might advance one fibrosis stage every 7 years, sometimes even faster depending on other factors.
Wow, one stage every 7 years.
Yeah. This is why intervening, trying to halt or reverse that inflammation is so urgent. Ultimately, it's estimated that up to 20% of patients who are diagnosed with NASH will eventually progress all the way to cirrhosis.
That acceleration is frankly frightening. Now, let's try and bring this back to the hospital floor, to targeted screening. You know, we're often tempted, especially in the hospital, to run every test possible.
All right, the shotgun approach.
Yeah, but the American Gastroenterological Association, the AGA, they actually provide some specific guidance here, don't they?
They do, and they're quite explicit about it. They state that routine screening for NAFLD in all hospitalized patients is not advised.
Not advised. Why is that?
Well, the rationale is both practical and statistical. If you screen a general unselected population, the yield for finding advanced fibrosis is actually very low, and you risk consuming excessive resources, generating false positive, causing unnecessary anxiety in lower-risk patients. So our focus has to be targeted.
Okay, so we focus our attention, our resources, strictly on those individuals we already know are high risk.
Exactly. That means any patient presenting with known obesity, particularly central obesity, anyone with type 2 diabetes, or those patients who have multiple concurrent metabolic risk factors like the hypertension and severe dyslipidemia we mentioned.
Right. So if you admit a patient, let's say for, I don't know, a routine elective surgery or maybe an exacerbation of heart failure, and you happen to notice their labs show some mild LFT elevation, maybe their BMI is 35, and they have known type 2 diabetes.
That patient needs to be flagged. They must be earmarked for immediate risk stratification for NAFLD fibrosis. And the singular goal, as we established earlier, is identifying advanced fibrosis. That means F2 stage or higher.
Okay, why is F2 the specific pivot point? What makes F2 so critical?
F2 signifies clinically significant fibrosis. It's really the point at which liver-related outcomes, morbidity, mortality, begin to dramatically worsen. Once we identify F2 or greater, it triggers an immediate need for several critical next steps, such as prompt referral to hepatology, consideration of specific pharmacologic interventions, which we'll discuss, and initiating long-term surveillance protocols, both for HCC and, just as importantly, for aggressive cardiovascular disease management. Identifying that advanced fibrosis essentially moves the patient from primary care risk management territory into specialty-driven disease management.
Okay, that makes sense. F2 is the threshold for action. So moving from the why to the how, how do we efficiently identify that F2 or, F3, F4 fibrosis? We obviously can't subject every high-risk patient to a liver biopsy, especially not on the acute care wards.
Absolutely not. Biopsy is invasive, carries risks, and isn't practical for screening. This brings us to the evidence-based strategy that really should be standard practice for hospitalists now. The two-tiered approach using non-invasive tests, or NITs.
NITs, okay.
These NITs are the cornerstone because they are designed primarily to maximize the negative predictive value. We're using them first and foremost to efficiently and reliably rule out advanced fibrosis in those individuals who are actually low risk, even if they have some risk factors.
So it saves resources and unnecessary procedures.
Exactly. It prevents unnecessary specialist referrals and minimizes the need for invasive tests like biopsy.
And the first tier, the one that should be universally applied to our identified high-risk cohort, is the FE4 score.
That's the one. FE4 is our preferred initial assessment tool. Why? Because it's built entirely from readily available, low-cost laboratory values and just basic demographic data, stuff we usually have anyway.
Right. Age, AST, ALT, and platelet count.
Exactly. Calculating FE4 is essentially non-negotiable for these high-risk patients, whether they have known NAFLD or just unexplained abnormal LFTs. And the beauty of this score lies in its validated cutoffs. They immediately dictate our next clinical action.
Okay, let's walk through those cutoffs then. These seem essential for clinical flow.
Definitely. Starting with the low-risk range. If the calculated FE4 score comes back less than 1.3,
Less than 1.3.
you can reliably exclude advanced fibrosis, F2 or higher. This is a highly reassuring finding. Now, there's an important caveat for older patients, specifically those aged 65 and above. That threshold is slightly higher, less than 2.0 for them.
Okay, 1.3 generally, 2.0 if over 65. And what do we do for these low-risk patients?
These patients don't need an immediate referral. They can be followed more conservatively, typically with repeat FIB4 testing every 2 to 3 years, alongside ongoing lifestyle advice, of course.
Got it. Now, the opposite end of the spectrum, the high-risk category.
That's a FIB4 score greater than 2.67.
Over 2.67.
If you hit 2.67 or higher, the probability of that patient having advanced fibrosis is high. This score mandates prompt hepatology consultation. Depending on the clinical context and stability, this might trigger immediate consideration for a diagnostic liver biopsy, or at least the initiation of advanced surveillance protocols we talked about.
Okay. And then we have that gray zone, the indeterminate range.
Right. FE4 scores falling between 1.3 and 2.67. This is the crucial group where we can't confidently rule in or rule out advanced fibrosis based on FE4 alone. So we need to escalate our diagnostic workup using the second tier.
And that second tier involves?
For these indeterminate cases, the AGA strongly recommends moving to a liver stiffness measurement, or LSM. This provides the necessary refinement to hopefully push the patient more definitively into either a low-risk or a high-risk category.
Okay, LSM. What are the practical ways we measure that? What modalities should we be familiar with? And importantly, are they generally available in the inpatient setting?
Good questions. The sort of gold standard for non-invasive assessment of stiffness is vibration-controlled transient elastography, VCTE. It's commonly known by brand names like FibroScan.
Right, FibroScan. Heard of that?
The other main modality is magnetic resonance elastography, or MRE. Now, MRE actually offers potentially superior accuracy, especially in obese patients, but it's far less available and significantly more expensive.
So VCTE is the more practical option usually.
Generally, yes. VCTE, or FibroScan, is increasingly available. You might find it in specialized hospital medicine units, GI clinics, or outpatient liver centers. However, a real logistical challenge for us as hospitalists is often accessing VCTE rapidly while the patient is actually admitted.
Yeah, I can see that being tough.
Right. So this frequently translates into needing to arrange an urgent outpatient follow-up, often coordinated by the consulting hepatology team, specifically for the VCTE test.
Okay, so when we combine these two tiers sequentially, FEB4 first, then LSM if needed, what kind of prognostic power are we actually talking about? How good is this strategy?
It's remarkably good. The sequential use of FEB4 followed by VCTE offers the highest diagnostic and prognostic accuracy among the readily available non-invasive strategies. There's solid data demonstrating that patients who have a FEB4 score of 1.3 or greater and also have a high VCTE measurement, typically a cutoff around 12.0 kilopascals kPa is used.
Okay, FEB4 equals 1.3 and VCTE 12 kPa.
Those patients carry a dramatically increased risk of future liver-related events, like decompensation, quantified by an adjusted hazard ratio of around 12.4 in some studies.
Oh, a hazard ratio of 12.4. That's compelling evidence for adopting this two-tiered strategy routinely.
It really is. This combined dataset not only confirms the high likelihood of advanced fibrosis, but also predicts a significantly higher chance of future hepatic decompensation.
Okay. Now, before we move off this diagnostic pathway, we need to circle back and talk about refining this risk stratification for a specific, very common subgroup, the patient with diabetes.
Absolutely. Critical point. The presence of type 2 diabetes is a powerful clinical modifier in the context of NAFLD. We know diabetics are inherently at higher risk for NASH and fibrosis progression.
So even if a diabetic patient's FE4 score falls within that indeterminate range, say 1.8.
Exactly. Even if it's in that 1.3 to 2.67 range, the co-occurrence of type 2 diabetes substantially increases the pretest probability that advanced fibrosis is actually present.
So what does that mean for our clinical decision-making then? How do we act on that?
It means we absolutely must lower our threshold for ordering that secondary testing, the LSM. If a diabetic patient falls into that indeterminate FIB4 range, we should prioritize them for BCTE or MRE much more aggressively, much sooner than we might for a non-diabetic patient with the same ABI4 score.
Okay, so diabetes acts as a crucial flag. It enhances the positive predictive value of any subsequent test, making the investment in getting that VCTE or MRE much more justified in those indeterminate cases.
Precisely. Don't sit on an indeterminate FIB4 in a diabetic patient. Push for the LSM.
Okay, that's clear. So we've established that FIB4 plus VCTE is the pragmatic, cost-effective standard for routine practice. But we're hearing more and more about emerging non-invasive biomarkers, particularly blood tests. We need to understand where they fit in.
Right. There's a growing landscape there.
We're talking about these proprietary serum tests, things like the enhanced liver fibrosis test, the ELF test, and maybe PROC3. Where do these newer markers fit into our kind of day-to-day clinical workflow?
Yeah, it's a good question because you do see them mentioned more. Generally, right now, they're recommended primarily as adjuncts or secondary options.
Why secondary?
Mostly because of cost and accessibility limitations, especially if you're not in a major academic center. However, we can't ignore their potential advantages, particularly in terms of accuracy, the ELF test, for example.
Tell me about ELF. What is it measuring?
So ELF is a composite score. It's derived from 3 specific serum markers. TIMI-1, tissue inhibitor of molecular proteinase 1, hyaluronic acid, HA, and P3NP, procollagen type 3 N-terminal peptide. These are markers related to matrix turnover and fibrosis deposition, and ELF demonstrates consistently higher diagnostic accuracy for detecting advanced fibrosis compared to ABI4 alone.
Higher accuracy. Can you quantify that difference, roughly?
Sure. If you look at the AUROC values of the area under the receiver operating characteristic curve, a measure of diagnostic accuracy, ELF consistently shows AUROCs in the 0.80 to 0.85 range for identifying advanced fibrosis.
Okay, 0.80 to 0.85. And FEV4 is typically...
FE4 typically sits a bit lower, maybe more around the 0.73 to 0.79 range, depending on the study population. So objectively, ELF appears to be a more precise single blood marker for advanced liver disease.
So, if it's objectively more accurate, why isn't it the first-line test? Why aren't we just ordering ELF instead of FE4? Is the cost difference really that substantial?
It is substantial, yes, and so is the accessibility issue. Remember, FE4 relies on labs, AST, ALT, platelets that are run everywhere, every single day with rapid turnaround.
Sure.
ELF requires specific proprietary testing methodologies. It's often processed in specialized labs, which can lead to slower turnaround times and significantly higher expense. Therefore, in the context of busy hospital medicine practice or even routine outpatient screening,
It's just not as practical as first line.
Exactly. We tend to use ELF primarily in situations where maybe elastography like VCTE is unavailable, or perhaps it was technically unsuccessful, which can happen in very obese patients. Or it can be useful when the FAPI-4 score is stuck in that indeterminate range, and we need a highly reliable blood test to help confirm the decision about referral or further workup.
Okay, so it serves as a potentially powerful tiebreaker or an alternative if VCTE isn't feasible.
That's a good way to think about it. And the sequential use, or combining these biomarkers, seems to offer really extreme certainty in some cases.
Right, what are the key scores we need to remember for that kind of combination if we were to use both?
Well, when you combine them, the positive predictive value, the PTV, can skyrocket. For instance, data suggests that combining a high ELF score, usually defined as 9.8 or greater, with a simultaneously high FABI4 score, say 1.96 or greater.
High ELF 9.8 and high FABI4 1.96.
That combination yields a positive predictive value of around 95% for significant fibrosis, F2 or higher. That level of certainty is incredibly valuable for confidently ruling an advanced disease and justifying an immediate, high-priority hepatology referral.
95% PPV, that's hard to ignore.
It is. And conversely, having very low scores on either tests like an ELF below 7.7 or a FABI4 below, say, 0.30 can be very reassuring for reliably ruling out advanced disease.
Okay. And what about PROC3? We hear about that sometimes, especially in clinical trial contexts.
PROC3 is particularly interesting scientifically because it measures active collagen type 3 formation. It's considered a more direct marker of active fibrogenesis, the actual process of scar tissue being laid down.
So it measures the rate of scarring almost.
In a way, yes. It shows great promise, especially for tracking histological response to new NASH drugs in clinical trials. However, for current routine clinical risk stratification, its role is still largely investigational. It's not yet established in widespread diagnostic guidelines like FB4 and LSMR.
Okay, so PROC3 is more research-focused for now. Our practical reliance needs to remain on that highly validated FIB4 plus or minus LSM strategy.
That remains the pragmatic, evidence-based approach for everyday practice.
All right, so now let's say we stratified the risk. We know if the patient likely has advanced fibrosis or not. We need to shift gears completely now to management. Because regardless of the stage, whether they're S-day with simple steatosis or F4 with cirrhosis, the underlying pathology demands a foundational management approach.
Absolutely. And these principles, while largely extrapolated from massive outpatient data sets, they must be ingrained in our inpatient education and, critically, our discharge planning.
And the absolute cornerstone of everything we do, the first thing we have to talk about is lifestyle modification. What are the specific evidence-based targets here? What do we need to communicate effectively to our patients?
We have to be crystal clear with patients that this is dose-dependent. The benefits scale with the effort. So a modest weight reduction achieving about 5% or more loss of their total body weight.
Just 5%.
Just 5% is generally sufficient to see improvement in simple steatosis. It can actually reduce the amount of visible fat in the liver. However, to achieve actual histological improvement in NASH, meaning reduction in inflammation and ballooning, and most importantly, to potentially regress or at least stabilize fibrosis.
Which is the ultimate goal for prognosis.
Right. The patient really needs to aim for significant, sustained weight loss, somewhere between 7 and 10% of their total body weight.
Okay, 7 to 10% for NASH and fibrosis improvement, that's a high bar. Hitting that target is incredibly difficult for most people, especially long-term. How do we counsel them effectively while they're stuck in a hospital bed, maybe feeling overwhelmed already?
It's challenging, no doubt, but we need to start the conversation. We should be advising structured weight loss programs. The intervention shouldn't just be eat less, move more. It should ideally combine energy-restricted diets, and the Mediterranean diet model has the best evidence.
We'll come back to that.
With regular aerobic exercise. And the physical activity recommendation is actually quite specific. Aim for 2 to 3 sessions of aerobic exercise per week, ideally targeting 65% to 75% of their maximum heart rate.
Okay, specific exercise goals.
And importantly, we must stress that physical activity helps even without hitting those major weight loss milestones. Exercise itself reduces hepatic fat content and improves insulin sensitivity, independent of significant weight change. So any increase in activity is beneficial.
That's a good point to emphasize. Don't get discouraged if the scale isn't moving dramatically at first. Now, regarding diet, you mentioned the Mediterranean diet. Why that one specifically? What's the evidence?
It's not just about simple calorie restriction, although that's part of it. It's really about the quality of the fat and carbohydrate intake. The Mediterranean diet rich in monounsaturated fats like olive oil, nuts, avocados, plus whole grains, fruits, vegetables, lean proteins.
Less red meat, less processed food.
Exactly. It's proven to improve not only hepatic steatosis and inflammation, but also the broader cardiometabolic risk profile, the lipids, the blood pressure, the glucose control, which, as we keep saying, is the main driver of mortality in these patients.
Right. And one more lifestyle factor, alcohol. What's the guidance there?
We have to be firm on alcohol. For anyone with NAFLD, especially if they have NASH or any fibrosis, the advice should be complete restriction if possible, or at the very least, maximum limitation according to standard guidelines. Even moderate alcohol consumption can potentially exacerbate liver injury and definitely complicate the underlying pathology, particularly in patients who already have inflammation or fibrosis. No amount is truly safe in this context.
Okay. So lifestyle is paramount. But what happens when lifestyle changes are insufficient, or maybe we're dealing with established biopsy-proven NASH? We start looking toward pharmacologic interventions. What are our proven, albeit limited, options right now?
Right, and the options specifically for NASH histology are indeed limited. For biopsy-proven NASH, we really have 2 primary agents to consider, both with significant caveats.
Okay, number 1.
First is Pioglitazone. It's a thiazolidinedone, an insulin sensitizer. This should be considered particularly for patients who also have type 2 diabetes, as it directly targets insulin resistance and has shown benefit in reducing hepatic inflammation and improving histology in NASH trials.
Okay, Pioglitazone, especially in diabetics, what's the typical dosing?
Dosing is typically around 30 to 45 milligrams daily.
And the risks? the caveats associated with Pioglitazone.
We absolutely must monitor for the well-known side effects. That includes weight gain, which can be counterproductive, peripheral edema, and importantly, a potential association with precipitating or worsening heart failure in susceptible individuals.
So careful patient selection is key.
Very key. And it's also crucial to remember Pioglitazone is generally not recommended in patients who have already progressed to established cirrhosis, mainly due to those fluid retention concerns.
Okay, no Pioglitazone in cirrhosis. What's the second agent for biopsy-proven NASH?
The second agent is vitamin E, specifically alpha-tocopherol,
Vitamin E.
dosed at 800 international units, IU, daily.
Yeah.
This is considered only for biopsy-proven NASH in non-diabetic adults.
Only non-diabetics. Why that restriction?
We must strictly adhere to that restriction because studies have simply not shown a clear benefit in patients with type 2 diabetes. And beyond lack of efficacy, there are potential long-term safety concerns associated with chronic high-dose vitamin E intake.
Such as
A possible small increased risk of all-cause mortality reported in some meta-analyses, and maybe an increased risk of prostate cancer in certain male populations. So the risk-benefit calculation is different for diabetics. And again, just like Pioglitazone, vitamin E is also contraindicated once a patient has developed cirrhosis.
Okay, so vitamin E only for non-diabetic adults with biopsy-proven NASH and not in cirrhosis. This really highlights a major gap, doesn't it? Currently, we have precisely 0 FDA-approved agents specifically for the treatment of NAFLD or NASH itself.
That's the stark reality. 0 approved drugs for the primary indication. This forces us to leverage drugs that are approved for the common comorbidities of NAFLD.
Right, which brings us to the newer diabetes and weight loss medications.
Exactly. This is where the GLP-1 receptor agonists, drugs like semaglutide, liraglutide, tirzepatide, and the SGLT2 inhibitors like empagliflozin or dapagliflozin become absolutely essential tools in our armamentarium.
Even though they aren't approved for NASH.
Correct. While primarily approved for type 2 diabetes and our obesity management, they have demonstrated significant secondary benefits in patients with an LRBIL. They not only promote often substantial weight loss, which we know is key, but growing clinical evidence shows they can also improve steatosis, normalize liver enzyme levels, and very importantly, dramatically lower overall cardiometabolic risk.
So we should be aggressively considering these agents in our eligible NAFLD patients who also have T2D or obesity.
Absolutely. They address multiple facets of the underlying metabolic syndrome simultaneously.
Okay. And for the patient with morbid obesity, where lifestyle and medications might not be enough, we can't overlook the most powerful intervention we have for sustained weight loss and potential disease reversal.
You mean bariatric surgery?
Exactly.
Bariatric surgery is a crucial option that needs to be considered for selected patients with morbid obesity who meet the established criteria. The evidence supporting it is robust.
What does the evidence show specifically for NASH?
It shows that bariatric surgery leads to substantial and crucially sustained weight loss. This translates into resolution of NASH histology in a high percentage of non-cirrhotic patients. Furthermore, large studies have shown it reduces overall mortality, cardiovascular event rates, and even cancer-related mortality in these populations.
So it should be discussed as a viable, potentially life-saving, long-term therapeutic strategy for the right patient.
Without question, especially for those struggling to achieve and maintain the necessary weight loss through other means.
Okay, so all these interventions, lifestyle, PO, FIT-E, GLP-1s, SGLT2s, surgery, they all kind of revolve around or synergistic with one final, absolutely non-negotiable principle: aggressive control of the comorbidities.
You keep coming back to it, and rightly so. Since cardiovascular disease is the #1 killer in this population, we must prioritize achieving and maintaining optimal, sustained control of their type 2 diabetes, their hypertension, and their dyslipidemia.
This often involves statin therapy, and we really need to counter that pervasive myth, that fear, that statins are inherently unsafe in liver disease.
Yes, please. Can you emphasize the safety data regarding statins in the NAFLD population, because so many providers and patients remain hesitant as soon as they see any elevation in LFTs?
Right. And that hesitation is largely unfounded based on the current extensive evidence. Statins are not only safe, but are highly recommended for dyslipidemia management and primary or secondary cardiovascular risk reduction across the entire NAFLD spectrum. That includes patients with compensated cirrhosis.
Compensated cirrhosis, too.
Yes, even in compensated cirrhosis, the benefits for CVD prevention generally outweigh the risks. Minor transient elevations in liver enzymes alone should absolutely not deter appropriate statin use. The cardiovascular benefit, especially in this high-risk group, far outweighs the minimal potential hepatic risk for most patients. We should be treating their hyperlipidemia aggressively.
It's a critical message to get out there. Don't withhold life-saving statins because of mildly elevated LFTs and NAFLD.
Exactly. So ultimately, managing NAFLD isn't a short-term fix. It's a complex, chronic, long-term disease. It really demands a multidisciplinary approach that goes beyond just the hospitalist and the hepatologist, right?
Oh, absolutely. Success requires a team. We need to set the patient up for individualized long-term care that actively involves endocrinology for diabetes and metabolic management, nutrition specialists or dietitians for ongoing dietary support, and often behavioral health professionals to help address adherence challenges, motivation, and the psychological aspects of chronic lifestyle change.
And the hospital stay, even if brief, is really the ideal time to initiate that coordination, to plant the seeds for that long-term multidisciplinary follow-up plan.
Precisely. Make the referrals, start the education, set the expectations before discharge.
Okay. Let's shift our focus now specifically to the patients who are already in the advanced stages of the disease, or perhaps are admitted acutely ill with concurrent NAFLD. These represent the highest risk scenarios, and they require some special clinical nuance from us as hospitalists.
They certainly do. And the prognosis of advanced NAFLD, meaning F3 or F4 fibrosis, is frankly sobering. Once patients reach this stage, their all-cause mortality risk rises sharply compared to those with mild or no fibrosis.
And decompensation is the real tipping point.
It is. Once hepatic decompensation occurs, the development of ascites, spontaneous bacterial peritonitis, hepatic encephalopathy, or variceal bleeding, the hazard ratio for death increases dramatically. We're talking maybe 6.8 times higher risk of death compared to compensated cirrhotics.
Wow. And how quickly does that transition happen?
The transition from compensated to decompensated cirrhosis in NAFLD occurs at a rate of roughly 8 to 10% per year. So these are very high-risk individuals who need close monitoring and specialized care.
Okay. Now, for the hospitalist managing these patients, especially when they come in acutely ill for another reason, there's a crucial diagnostic nuance we need to be aware of. You mentioned the FIB-4 score relies on common labs.
Right. AST, ALT, platelets.
But those lab values can be completely thrown off by acute conditions, can't they?
That is a major, major caution. Acute inflammatory states, think sepsis, severe heart failure, exacerbation, even acute kidney injury or major surgery, can transiently alter AST, ALT, and platelet counts, sometimes quite significantly.
So what does that mean for interpreting FIB-4 on admission?
It means that if a patient is acutely ill, the FIB-4 score calculated right upon admission may be temporarily unreliable. It could be misleadingly high due to the acute illness itself, not necessarily reflecting the true baseline degree of liver fibrosis.
Okay, so how should we proceed then? If the patient is acutely ill, but clearly meets the high-risk criteria for underlying NAFLD, should we just ignore the FIB-4 calculated during that acute phase?
Not ignore it entirely, but use it with extreme caution. Use the score to flag the underlying risk, yes. But the definitive interpretation, or the decision to refer based solely on that single FIB-4 score obtained during an acute illness, should probably be postponed.
So contextualize it.
Exactly. Contextualize all non-invasive testing results to the acute clinical scenario. The priority is always to stabilize the acute condition first. Then, ideally, schedule repeat testing, repeat the FIB-4, perhaps pursue LSM post-discharge, or at least once the acute illness has fully resolved, to get a more accurate picture of their true baseline liver status.
That makes sense. Don't make irreversible decisions based on potentially labile acute labs. Now, once we do establish that the patient has progressed to cirrhosis, F4 fibrosis, our management options become significantly more restricted, especially on the pharmacologic side.
That's right. For patients with established cirrhosis, we strictly avoid both Pioglitazone and vitamin E.
Why avoid them in cirrhosis?
There are clear safety concerns, particularly regarding the risk of fluid retention and potential worsening of ascites or edema with Pioglitazone. And for both agents, there's simply a lack of proven efficacy or benefit once cirrhosis has developed. The potential risks outweigh any theoretical benefit at that stage. So if a patient with new onset cirrhosis comes in already taking one of these, we need to pull them off their medication list.
Okay, stop Pio and Vit-E in cirrhosis. Nutrition also becomes a bit of a tightrope walk in cirrhosis, doesn't it? Malnutrition and sarcopenia muscle wasting are highly prevalent and are themselves powerful negative predictors of outcomes like mortality and decompensation.
Absolutely. Sarcopenia is a huge problem.
So we need to prioritize adequate protein intake, but also manage potential complications like encephalopathy. How do we balance that?
We must actively combat the historical, often misguided fear of protein restriction in cirrhosis. Unless the patient has active, refractory, severe hepatic encephalopathy that is clearly protein sensitive.
Which is relatively uncommon.
Right. For the vast majority of cirrhotic patients, we should be advocating for individualized nutritional support with adequate protein intake. The target is generally around 1.2 to 1.5 grams of protein per kilogram of ideal body weight per day.
1.2 to 1.5 grams per kilo. That's higher than standard recommendations.
It is higher, intentionally so, to prevent muscle wasting and frailty. Unnecessary dietary restrictions that contribute to a calorie and protein deficit must be avoided as they worsen outcomes. Consult nutrition support early if needed.
Good advice. Now, regarding medication safety and the ever-present issue of polypharmacy in cirrhosis, what are the specific cautions for us as hospitalists, particularly concerning some of the newer and existing metabolic drugs we've discussed?
Careful medication reconciliation at admission, during the stay, and at discharge is absolutely mandatory in cirrhosis. It's critical. Regarding specifics, statins, as we said, they are generally safe and indicated for cardiovascular protection in compensated cirrhosis.
Compensated, meaning no ascites, no encephalopathy, good synthetic function.
Correct. However, statins require extreme caution and very close monitoring, potentially dose reduction or even discontinuation in patients with decompensated cirrhosis, especially those with severe ascites, refractory edema, or high MELD scores. The risk-benefit ratio really shifts when the liver is actively failing. Hepatic metabolism is impaired, raising drug levels and potential toxicity.
Okay, caution with statins and decompensated cirrhosis. What about those newer agents we praised earlier, the GLP-1 receptor agonists? Can they be used in cirrhosis?
They may be considered cautiously in patients with compensated cirrhosis, especially if there's concurrent type 2 diabetes, because their cardiometabolic benefits remain attractive. But again, close monitoring is absolutely essential.
Why the extra caution?
Because these drugs can cause significant gastrointestinal side effects, like nausea, vomiting, or delayed gastric emptying. In a vulnerable cirrhotic patient, this could potentially exacerbate malnutrition or, more dangerously, lead to volume depletion, which might precipitate acute kidney injury or even hepatorenal syndrome. So we have to carefully balance the potential cardiometabolic benefit against the acute safety risks in the cirrhotic liver.
Okay, use GLP-1s very cautiously in compensated cirrhosis, probably avoid in decompensated. Finally, perhaps the most critical piece of long-term planning for every patient diagnosed with NAFLD-related cirrhosis, the one thing that is absolutely mandatory upon discharge.
Hepatocellular carcinoma surveillance, HCC surveillance, this is completely non-negotiable.
Why so critical?
Because patients with cirrhosis from any cause, including NAFLD and NASH, are at significantly increased risk of developing primary liver cancer. Surveillance aims to detect HCC at an early, potentially curable stage.
And what does surveillance entail?
The standard recommendation is an abdominal ultrasound, with or without serum alpha-fetoprotein, AFP, every 6 months, lifelong. Given the often rapid progression of HCC that can occur in this specific cohort, establishing this surveillance protocol and ensuring the patient clearly understands its importance before they leave the hospital is honestly one of our primary duties as discharging physicians.
I'm sure the follow-up plan includes that biannual ultrasound.
Okay.
Got it.
Don't let them fall through the cracks on surveillance.
Okay. Well, this has been an incredibly comprehensive review. I feel like we've really focused exactly where the hospitalist needs guidance on aggressive, evidence-based risk stratification and then targeted, stage-appropriate management.
I hope so. And just to reiterate the central clinical utility here, our inpatient management of NAFLD really has to revolve around 2 core tenets, I think.
Okay.
First, consistently applying that validated FAB4 followed by LSM pathway. Use it to efficiently triage patients, identify who truly has advanced fibrosis, and thereby guide appropriate, timely hepatology referral.
Stratify the risk accurately and efficiently.
And second, initiating and meticulously planning for the aggressive, long-term, multidisciplinary management of all those underlying cardiometabolic comorbidities.
Right, because, as we've hammered home, it's the advanced fibrosis that really locks in the need for specialist care, HCC surveillance, and specific pharmacologic restrictions related to the liver.
Right.
But it's also the unmanaged type 2 diabetes, the hypertension, the dyslipidemia, the obesity that will ultimately be the actual cause of death for the majority of these patients due to cardiovascular events.
Exactly. So our discharge planning has to be robust. It must ensure every patient leaves not just with follow-up appointments, but with a clear, actionable plan for long-term lifestyle intervention and rigorous comorbidity control.
We've covered the whole pathway, it feels like. From understanding the risk factors in genetics, through the non-invasive testing cascade, management principles for all stages, and down to the specific challenges of managing decompensated disease and ensuring surveillance.
It's a lot to cover, but essential knowledge for hospitalists today. Perhaps we can leave you, the listener, with one final question for reflection. Something to consider as you coordinate that post-discharge care, especially for your patients who present with established NASH cirrhosis.
Okay, a provocative thought to end on.
Given the strong genetic component we discussed earlier, remember those PNPLA3 variants and others? And knowing the incredibly high prevalence of NAFLD in the general population?
Yes.
Should we, as clinicians encountering a patient with end-stage liver disease from NASH, be proactively counseling them about the risk to their family, and perhaps even advising screening for advanced fibrosis, specifically in their first-degree relatives, their parents, siblings, children?
Screening asymptomatic family members of patients with NASH cirrhosis.
It's a profound question, isn't it? If the genetic risk is indeed high within that family, initiating earlier screening in those relatives could potentially identify advanced liver disease years, maybe even decades, earlier than current standard practice allows.
Which could offer a true window of opportunity for preventative intervention before they reach that irreversible F3 or F4 stage.
Exactly. A compelling opportunity, perhaps, to potentially shift the devastating course of this silent epidemic one family at a time.
A very powerful thought to consider. Thank you for joining us today on the Hospital Medicine Unplugged podcast.